Hi all, welcome to the second episode of our panel discussions. So today the topic for discussion, as you all know, is management of snakebite. As with the previous episode, here also we will be taking questions from all of our audience. So feel free to put in your questions in the chat box. We will be taking that at the end of the session. For this discussion today we have Dr. Girish Kumar sir, our HOD, Dr. Dhanasekaran sir, Professor Emergency Medicine, and Dr. Sri Krishnan, Consultant Emergency Medicine at Amrita Institute of Medical Sciences. So we will stick on to the same format which we followed last time. We will be asking questions to the panelists, and at the end of the session we will take questions from the audience. To start with, the first question is to Girish Kumar sir. So the normal first question whenever we start a snake bite kind of a presentation, the common big four snakes. If you can just elaborate on that, and what is the other poisonous snakes which we are commonly finding.
So when we start telling about snakes in India, there are around 300 plus poisonous snakes are there in India. But big fours, what Dr. Shabrish told is, one is common thing is common cobra. What we routinely see in our area is common cobra, spectacled cobra. And one more cobra is there that is that does not come in big fours. Big fours are mainly for treatment purposes. Okay, so one is common cobra, common crate. Both are neurotoxic bites. Then other two snakes come in, viper, saw-scaled and other type of vipers. Russell's viper. Then we have like Kerala and all, we have this sea snake, but it is bites are not very common in our area, but it is common in India. Sea snake bites are common in India. So if you tell big fours, all these four previously I told that is come in big four, but the why we are calling it as big four, not because they are big, because we have only treatment for that. Another big snake which is mainly seen in our area, that is HNOS pit viper. The difference between that big four and the fifth big snake is treatment aspect. We are not able to cover with ASV this HNOS pit viper. So whatever it is, whether it is big four, big five, or any other snake, as a clinician, we always see what is the clinical finding. Whether you are bitten with a small snake, big snake, poisonous snake, non-poisonous snake, or poisonous snake with dry bite or real bite, whatever it is, as a clinician, we should only see the clinical features and treat. All these things are academic purpose. We have different classes of snake. We know that some snake has got neurological feature, some have got hematological, some have got renal involvement. Whatever it is, we always treat with anti-snake venom in India, and we always treat according to clinical manifestations.
Sir. I think that made it very, very clear. The concept of big four is predominantly with regards to the polyvalent anti-snake venom which we have here, which covers for the big four snakes. Clear. So second question is to you, Dhanasekaran sir. Yes. Sir, is there any seasonal kind of variations in the type of bites or the kind of snake bites predominance in our part of the world?
Yes, it is actually there is a seasonal variations in the incidences of the snake bite. See, usually snake bites are very common in village and forest places, but now there urbanization. So the people start moving and the materials are being brought from different villages and forest areas. So along with that, the snakes also started coming to the city and the urban areas. And regarding the rainy days and during the flood, so most of the snakes also start coming out from the original dwelling places. So these are some of the instances where the snake bites are very common in urban and city.
So monsoon kind of time we are getting more of snake
the
bites.
building constructions are
Construction sites,
inside site and all. And then uncared areas in the urban areas, not regularly visited, not regularly taken care of. Even in the house itself, dump yards, which we do not give proper attention periodically. These are all the things which may be causing the incidences to rise in the urban area.
Sir. Right, sir. So, next question to Krishna. Krishna, how important do you think is the correct identification of the snake in the management? I think sir already mentioned a little bit on the topic.
Again, when it comes to the management of snake bite, the most of the time what we see is that the bystander bringing to the snake to the ED killed or live, even live sometimes, majority of the time killed snakes. So they think that there is got a significant role so that the doctor can understand what exactly is the snake and they can plan the management according to that. So that is a common misconception that everybody is having. But for a treatment perspective, as sir has already touched upon it, treatment perspective, we have got something called as a syndromic approach. I think that we'll come to the discussion later. So depending upon the clinical features only, we will be managing the patient. So even if somebody is bringing in me a Russell Swiper, and if the patient is totally asymptomatic, I'll be monitoring him continuously. And if only he have got some indication to start anti-snake venom, we'll be starting the treatment. Otherwise, the patient will be kept under observation. So that is one thing. And there can be instance of dry bite. So that is one thing that is very common. If the snake has already exhausted his venom, and sometimes it has already done his spraying, and it has exhausted its venom and it is biting the victim. So sometimes the venom would not have injected. So as a result, there will not be any features of envenomation. That is one. And second thing is that sometimes if the patient, somebody is bringing for example, a rat snake to me, and if the patient has got symptoms, we will definitely go ahead with anti-snake venom. So it's only the clinical manifestation. So the reason being that maybe exactly the same snake that they are not bringing in, something else would have bitten the patient, and they are bringing in some other snake that has been in and around the situation. Maybe the rat snake is one of the very common snake that we see very commonly. So maybe they would have brought that snake. So the only thing that we need is the clinical features, and we go ahead with only with the clinical features for the management of snake bite. So I think that concludes this question.
Moving on to the next question. This is a common question which we find when we discuss with the public. Does the bite site, whether the leg or head, things like that, influence the outcome or rapidity of spread of venom?
So the site of the bite is it is important actually. Why it is important? One important thing is if the bite has directly to a vein. So that we cannot tell whether it is on the lower part of the leg or upper part of the hand. We cannot tell. Sometimes the fang has directly gone into the vein and inject the vein like an intravenous injection. In that case, the venom spread is very, very fast. In that case, clinical symptoms come very fast. Another important thing is, suppose somebody has bitten by a snake, the fear of the death, that has created more problem than actual the venom itself, because suddenly tachycardia can occur. The venom itself, the circulation of venom has become faster, and the clinical finding because of the neurological problem, that vasovagal type of syncope or post-fear syncope, that itself can create so many problems. But however, your question is whether the site of the bite like it got any prognostic feature or not. Suppose the bite is in the lower limb and it takes some time to travel to the heart or brain. It takes some time. But if you see the circulation of our human body, it is everywhere. Blood is reaching everywhere in the same manner. But however, there may be slight difference depending on the site in the like lower limb and upper limb or the face, slight difference. But if you are treating a snake bite, it's all within 30 minutes, almost all clinical findings can set in. So that does not have big impact. But however, as a common public, they are not aware about our snake bite management protocol. They think that the bite is in the lower limb. They can do something there like tying and all these things can do, and patient survives more than getting a bite on the face. But that clinically it is not having any big impact when you are treating the patient, whether it is upper limb, lower limb, wherever it is, within half an hour the clinical feature will set in. But if it has gone to a vein, then within minutes or within seconds it can create problem.
I think that answers the question very well. Moving on to Dhansharan sir. Sir, can you just summarize the first aid management in snake bite?
The first aid is being done actually where the victim has been. So it may be in a remote place, like not accessible for transportation. And they may have to move the person directly from there by some means to the nearest hospital where the antivenoms may be available. So whenever possible in the site, see the first thing is console the victim,
Okay,
not to be afraid. Don't worry about it. Don't
Okay.
move any parts of the body.
True.
There are only two goals in that. One is to reduce the
Anxiety.
spreading of the venom.
Okay, sir.
And number two, as quickly as possible, transportation to the appropriate facility.
Okay. Okay.
The appropriate facility where the antivenom may be available.
Okay.
These are all things. So the calming down and not allowing him to move any part of the body and let him be quiet and take rest. In the meantime, look into any tight objects like bangles or rings in the
Bitten area. Okay.
limb itself, and also watches, wristwatch, and other ornament jewelry we can remove all the things from that place.
Okay.
And regarding the wound,
Okay.
see there may be injection site, some wound may be there, to wash it or clean it. So only condition where we are allowing to wash that wound particularly is when we are taking long time to travel, shift the patient to another place. And in some countries, some they are adapting from the side, they are using the venom testing kit.
Okay. Okay.
So if it is not to be used, then washing will be abolishing the traces. So then otherwise we can have a gentle washing.
Okay.
And number two, regarding the immobilization part, there are two things: straight immobilization and pressure bandage application.
Yes.
The pressure bandage means it's not a tourniquet like objects. It should not be applied.
Okay.
So the say elastic type of this one or whatever the common materials in long strips and broad width. So we can apply it.
Okay.
See, it is just to occlude the lymphatic system, not to occlude the arterial system.
Okay.
So it will be properly done.
Okay.
And over and above, we will be immobilizing the site. It is in the extremity, for example, lower extremity, and the ankle joint and the leg can be immobilized up to the knee joint. Both the joints will be involved.
Okay.
See, in the upper limb means the hand and the elbow and the forearm. So all should be immobilized, and in the upper arm we can use a sling also in addition.
Okay, sir. Right.
And apart from that, there are some don'ts.
Okay.
So regarding the wound,
Okay,
no
sir.
question of incision
Yeah.
or oral sucking
Okay.
or using a mechanical suction pump to relieve it. Only thing, the mechanical pump can be used only within 3 minutes of the bite has happened, then it may have some meaning. Otherwise, don't.
That's
do
also a bit controversial kind of.
it. There is a controversy in that one. And I don't give the patient during the shifting and all any medications,
Okay, okay.
especially beta blocker or aspirin, NSAIDs, which will again mask or increase the worsen the hematopoietic envenomation.
Okay.
So and no alcohol.
Nothing.
Nothing. Yeah, that's also in some villages
sir.
and all, they used to give alcohol for temporarily like
Right,
that. And we have to shift the patient very quiet
Okay.
without moving any
Okay,
parts of him. And again, keeping the limb whether to the heart level or lower level, that depends upon whether it is only pure neurotoxic which is causing paralysis without any local tissue damage. In that condition, we may be able to raise it. So otherwise, we keep it. If it's going to cause this, local swelling and all, we can avoid that process.
I see. Thank you, sir. You covered it very extensively. We'll move on to the next question to Girish, sir. So usually we classify the presentations into local signs and systemic signs. If you can just throw some light into these two things.
Okay. Local signs has got very important role in snake bite.
Okay.
Why this is because when you have a poisonous bite or non-poisonous bite or a dry bite, that means a poison snake has bitten, but it has not injected the venom.
Okay.
Venom is a protein.
Yeah.
Whenever you inject a protein to our body, there will be some cellular reaction surrounding that protein, especially when it is a toxin. So local swelling has got some importance in managing the snake bite, because when you get a bite, immediately if you are seeing local swelling, you should understand that there is a poison injected to the body. Then after next day, normally in viper bite and all, we can see the cellulitis, cellulitis, blisters and all, but it takes some time. But the same day itself, you can see some lymph nodes.
Okay.
Like lower limb means in the inguinal area, we can get tender lymph nodes.
Okay.
That is also give some clue about the poisonous bite or not.
Okay.
So most important thing is always the local examination, that you can see the fang marks.
Okay.
Fang marks, if you take fang marks of a cobra, it will be larger.
Okay.
You could take a fang mark of a crate, it will be smaller. Sometimes you can miss also crate bite. But a local swelling will be there almost all snake bites, and it will be more in viper bites.
Okay.
So that you should examine properly. Look for fang marks, look for local swelling, look for any like indurations on the surrounding area,
Okay.
redness,
Okay.
then local lymphadenopathy, whether the patient has got some abdominal pain, all these things. This is applicable for both upper limb and lower limb. So fang marks has got definitely an important role. If it is a non-poisonous bite, you get scratch marks.
Okay.
Rat snake and all, you get scratch marks. That has got some importance in managing the snake bite. But once you see that, you should be alerted that there is a poison has gone inside. So once you diagnose poisonous snake bite, then treatment will become more easy for us.
Okay. And systemic symptom.
Systemic manifestation, if you now we know that snakes have got different types of systemic presentation.
Okay.
One is neurological manifestation, another one is hematological manifestation,
Okay.
third one is renal manifestation. These are the three important systems. In that, what we have observed is most of the bites, neurological bites, they come with slight ptosis.
Okay.
And books have explained that you keep the eyes, sometimes it can be reversed. I have never tried it, but ptosis is the one of the common presentation of neurological bite. So when the patient come, you talk to the patient will be having some inability to talking.
Okay.
So some breathlessness because of the weakness in the diaphragm, respiratory muscles. Then ptosis will be there, difficulty in swallowing, neck holding, difficulty in neck holding, single breath count, that you ask the patient to count 1 to how much ever he can count in one breath. That will be slowly coming down in poisonous snake bite like cobra and crate. Whereas in bites like viper bite, they immediately you don't see anything. But 20 minutes clotting time, that's a lab investigation, we'll not discuss now. But even then, when you're pricking, that putting an IV line, taking blood, or doing a sugar test in the fingertip, all these things, sometimes you can see the bleeding is continuous.
Yes.
But most of the time, immediately if you are getting the bite, this may not be there. It takes some time.
Okay.
It takes at least minimum 6 hours to happen.
Yeah.
So that, but however, we have to follow these patients for any bleeding tendency. Bleeding tendency can occur in the mouth, in tongue, eyes, all these things can occur. Renal failure, it takes some time. Most of the patients who is having viper bite or HNOS pit viper, next day or within 1 or 2 days, their creatinine will come up, then they develop anuria, all these things. Most dominant clinical feature in neurological bite is ptosis. Any patient who is developing ptosis or unconsciousness, sudden without any reason becoming unconsciousness, that is also like young child becoming unconscious, who has not told whether snake bite has occurred. That all goes in favor of crate bite.
Okay.
Crate bite will not produce any pain. That is a problem. Small needles. So unconsciousness, ptosis, other type of respiratory weakness, all these things are common clinical presentation.
Okay, sir. Thanks, sir. Moving on to Krishna. The current thing is to go for a syndromic approach in management. So if you can explain a bit on that.
So as we know, for any toxins, we have got a toxidrome. That's what we call. So like you see like dilated pupils, you have tachycardia, you have okay, this toxic. So that like that we have toxidrome. Similarly, the WHO has come up with an certain guidelines for a syndromic approach. So classically, what we can see, commonly we can see 5 syndromes. So that is a commonly described 5 syndromes in an venomous snake bite. So coming to the syndrome number 1, where we have the patient is having a bite mark, and on top of that he has got hematological manifestation. So it is very clear and straightforward. It is from an hematological venom that is caused commonly by Viperidae species. So the commonly it can be a Russell's viper, saw-scale viper, or maybe a HNOS pit viper. So the classical it will be a Russell's viper and saw-scale viper. Local reaction with immediately hematological manifestation like a positive WBCT. Elevated PTNR and coagulopathy. So that will be the first syndrome. So now coming to the second syndrome, straightforward, we have a bite mark with a neurological manifestation. Bite mark with only neurological manifestation, then we can name it. It can be either due to The classical one is the Indian cobra, Naja Naja. So that is the one syndrome number 2. Now going to the syndrome number 3, where we can have both hematological and little bit of neurological manifestation. So little bit of hematological and neurological manifestation that classically seen in Russell's viper. So what we see is that Russell's viper will majoritively will have hematological features, but little bit of neurological features like ptosis, as Sal described, they can have not major like an acute flaccid paralysis, but they can have little bit of smaller cranial nerve involvement. So that will be the Russell's viper. Now coming to the next syndrome, that can be again, there is no local reaction, but there is neurological manifestation. That is the classical of common crate. So we have to be very specific why I am using this terminology. There is n number of crate in the world, and what we see commonly is the common crate. There is realignment. There are different types of crate that is in and around, but common crate can cause only neurological. That is what is the classical teaching. It causes only the neurological manifestation, but there will not be any local signs and swelling. So again, as I said, it is very difficult for us to diagnose a crate bite. The patient will be suddenly come with sudden flaccid paralysis, maybe unconsciousness. The classical history, when we look at the bite would have occur inside the house. So that is a history that we need to buy. When we are studying this initially, we thought it is just a theoretical thing, but once we start practicing, majority of the time it has come to be positive. So that is regarding the crate bite. So that is a syndrome 4, and finally we can have a syndrome where there is a lot of renal manifestation and local reaction and hematological manifestation, plus or minus hematological. Again, it can be Russell's viper and sea snake. So if there is hematological manifestation, it is in favor of Russell's viper. If there is no hematological manifestation, it is in favor of sea snake. So these are the classical 5 syndrome. So depending upon the big 4, or we can call it as maybe the big 5 now. So the big 4, Russell's viper, saw scale viper, Indian cobra, Naja Naja, and common crate, and finally the hum-nose pit viper and sea snake. So this will be the syndromic approach.
That made it very, very clear. Next question will be taking cue from your answer itself, sir. To Girish, sir. So regarding hum-nose pit vipers, so that is, as we initially mentioned, the role of our traditional anti-snake venom is questionable also. And how often are we seeing these, and also renal presentations, and what is the basic principles we are following in management?
Okay, hum-nose pit viper is like any other viper. Its bite is mainly kidney toxicity to kidney, and some hematological manifestation can be there. But when the patient come to emergency room, we will not be knowing that whether it is a hum-nose pit viper or any other viper. When the patient has got bleeding tendency, or elevated creatinine, we routinely start ASV, anti-snake venom, according to standard protocol. But the problem is, this will not, what we have seen is this ASV, what is available at present in India, is not having good action against hum-nose pit vipers venom. So the main problem in hum-nose pit viper, what we have observed is, they will not deteriorate, but their renal parameters will remain same for long time. Normally, the snake bite may require, if you give adequate treatment in the initial itself, their renal failure will recover in 2 weeks. Normally, what is normally seen is 2 weeks they'll recover. But hum-nose pit viper, they requires more time, like 2 to 3 months of dialysis. Most of these patients require longer time of dialysis to recover. But once they recover, they completely recover. But what we have understood from the treatment, ASV working against hum-nose pit viper is not that effective. It may not work at all, we don't know. But definitely when the patient come to ER, we start the ASV because thinking that it's another viper. We never drop the treatment. We continue the treatment as per standard protocol. But what we have observed is renal failure is remaining like persistent for a longer period, maybe 2 to 3 months. They require dialysis for a longer time. That is the main difference between hum-nose pit viper and other vipers.
Very clear, sir. Moving on to Krishna, especially in the WHO guidelines and all, there is a lot of emphasis on this 20-minute whole blood clotting time. So based upon that, I'm asking you 2 specific questions. One, most of us will know how to do it, but again, what are the limitations with this test, and how often should we repeat it in an ideal situation?
So the 20-minute WBCT or 20 minutes WBCT, whole blood clotting time, that has been the classically described test by WHO, because they have designed this for anywhere you can do, anywhere you should be able to do this test. Even in a small primary health center, you should be able to do this test. So that is the idea behind a 20 minutes WBCT designing. So the classical clotting time, we know we will take a blood and we'll shake it and see how much time the blood is taking to get clotted. But there is slight difference, as many of you already know, that we need to take 3 to 5 ml of fresh blood and keep it undisturbed in a clean glass container and for the next 20 minutes. And you have to see this after 20 minutes, if the blood is not getting clotted, that means the patient has gone in for DIC. So that is a very straightforward thing. So to have a 20 minutes WBCT positive means the patient already 80% of his coagulation factors are deranged and the patient is already in DIC. So there is no doubt you need to go ahead and start your anti-snake venom. So many of the time the problem what happens is the container that has to be taken should be clean glass container. It should not be clean at that point. It should be kept ready. So it should be kept dried and should be in the sunlight and should be kept ready when the patient is coming. Majority of the time what will happen, they will just clean it then and there itself and they just dry it with a towel and they will use it. There can be lot of problems in that. So a high chance of error, thinking that it is positive, we might give anti-snake venom. That is one of the major, and observer to observer variations can happen. Again, it has got no standardization, so there can be problems with 20 minutes WBCT. So that is my take on 20 minutes WBCT. That is supposed to be done in a peripheral setup where you don't have anything else, where you don't have tests like PTNR, APTT, where you have better coagulation profile markers. At least you can do a 20 minutes WBCT. And next question comes, how often? So again, how often is also depending upon your available resources. If you have a center where you can do PTNR or APTT every second hourly, maybe every fourth hourly also, that's fine. So 20 minutes WBCT is maybe you can use it as an initial test and later on you can use with another test. But in a peripheral setup where you don't have anything else, at least every hour you can just repeat every hour you can just see, you can't predict exactly. So when it is going to be positive, sometimes the venom injected is very small, it might take 6 hours for the WBCT to get positive. Maybe the venom injected is very much huge that it will within 1 hour itself it can become positive. So we cannot predict exactly what time it is going to be positive or when the response is going to happen. So ideally 1 hour, every 1 hour maybe the initial till it has become positive. Or what I suggest is that what we practice, that we have better resources, we have better testing available. Go ahead with PTNR every 2 to 4 hours. You can send a sample to the lab and maybe within 25 to 30 minutes, it's a good laboratory, you can get the result. So we are waiting for 20 minutes, meanwhile you are getting a lab PTNR, which is much more superior than a 20 minutes WBCT. So that will be my take.
I think that answers a very, very important question. Moving on to Girish sir. Sir, one thing probably which we don't focus too much is on the urine examination. So is there any relevance at all for urine examination in snake bites?
Urine examination is got importance in snake bite management, especially in the rural areas. Even in urban areas, our hospital also we follow the same protocol, but it is very useful in rural areas, especially bites which involves the hematological system or renal system. When normally when you know that when we examine the urine, we should not see any RBCs in the urine, especially in the male patient. Female patient up to 8 RBCs are accepted. But if the number of RBCs are large, RBC casts are there, urine output is coming down, pH is coming down, this all alters the urine function. But among most important thing is always RBCs or blood in the urine. All these things are very important, because I am not telling the microscopic aspects of the urine. As a clinician, when I treat a snake bite case in a primary center or secondary center where there is no microbiologist or pathologist available, when I look at the urine, if the urine is becoming a cola colored or a red colored urine, I should be very careful. I should understand that this patient is developing some intravascular hemolysis or some renal failure, something like that. And urine output is also very important. Since we are in a tertiary care center, every day we are able to do the creatinine levels. Some hospitals in primary care areas, they may not be able to monitor the creatinine every day. Their urine output, intake output chart is very, very important. So rather than going for a urine microscopy, that depends on another doctor's health. You can just watch the urine, color of the urine, amount of the urine, all these things are important. When you are getting a microscopy, that shows RBC, RBC cast, hemoglobin, all these things are also important. So all urine examination has got a very vital role in management of snake bite.
Like with urine, another thing which is very often overlooked in snakebite management is the pain management. Darshan sir, if you can just throw some light on how to manage pain in snakebite.
Regarding the pain management, so before
Sir.
going into the pain management,
Yes, sir.
so sedation we will talk about. See, for example, neurotoxic.
Yes, sir.
The patient will be slowly going for paralysis, but he will be having the cognitive function still intact.
Oh,
He will
okay.
be fully awake.
Yeah.
So these are all the patients. If there is no bite wound is there, or there is no pain in the bite site, simple sedation without any analgesic has to be selected for.
True.
So the main dictum is always go for the short-acting drugs,
Okay, okay.
because periodically we have to assess the patient.
True.
So in such cases we can even opt for propofol.
Okay.
So the criteria we have to keep in mind about the hemodynamic stability.
Okay.
So the blood pressure and pulse rate. So whenever the BP is normal or on the higher side, we can go for the propofol.
Okay, sir.
And other choices, low dosage of lorazepam can be given, but it is a long acting drug.
Okay, sir.
So ketamine can be chosen in lower dosages, analgesic,
okay.
just to make him quiet.
Okay.
So that regarding the pain part, so one is the local bite pain.
Okay.
Number two, there are occasions when the patient may go for compartment syndrome.
Right. True.
So third one is whenever the patient is landing up in an RS.
Okay.
Again, the drug selection is depending upon the degree of paralysis if it is a neurotoxic.
Okay.
And number two, the hemodynamic
Okay.
stability if it is a hematotoxic. So these are all the factors, and the renal involvement.
Okay.
So based on these three things, we have to select the agent.
True.
So here, if you want to go for simple parenteral, this one ketorolac is a
Ketorolac.
good choice. And then ketamine with midazolam in all smaller doses, titrated.
Okay.
And the one thing which we have to avoid regarding the pain management is aspirin
Okay.
and NSAIDs.
Okay.
So better to avoid all these things, because there may be renal toxicity already existing. It may be worsening this thing.
Okay.
And we may even go for combination with any of the fentanyl group of drugs, which is also short acting.
Okay.
Recently, dexmedetomidate has come,
Okay.
but usually the patient is irreversible. But in snake bite, how far it is the recommendation, there are not much studies.
So basically, we have to avoid aspirin, NSAIDs, and
No,
all, and
NSAID.
probably
The main
opioids
thing is
might
we have
be-
to keep in mind these two drugs.
and paracetamol also will have it.
In paracetamol, we can give for pain relief. The first line of choice, we can give it with the degree of the pain.
Yeah.
So we can go.
Okay, sir. Thank you, sir. Next question to Krishna. Even though we told that tourniquets are not at all indicated, we often find patients being brought into the ER with a very tight tourniquet. So, in situations where tourniquet is already applied, how should we be moving ahead?
Very relevant question, Shavadesh. Because majority of the time what we see, they will come with a tourniquet. Even though how much education you give to the public, they still feel tourniquet saves life. So that's what they think. So it is a big challenge for the treating physician whether to release the tourniquet or how to release the tourniquet. And next important thing, whether the swelling is due to the tourniquet or due to the bite itself. So it's a big challenging question for us the initial time. So the most important thing is that if they are properly applied so-called tourniquet, what will be an ideal to me, a small crepe bandage or a small cloth, so that at least one finger should be able to insinuate. If that is not the situation, then again we are in trouble. So what we practice, there is no recommendation as such, there is no guidelines as such for this. This is what we can follow. We thought we can apply this to our snake bite victims and we can practice this. What we'll do, we'll just above the tourniquet, we'll apply our normal BP cuff and we'll just inflate it above the systolic BP. Systolic BP. So systolic BP initially, and then we slowly release the tourniquet. And once the tourniquet is released, then we slowly come upon the systolic blood pressure. Slowly we'll deflate, and once it is to the blood pressure, what is the patient is having, we'll just remove the BP cuff. So the problems in that, why we wanted to do this, that is the question. Sudden release of tourniquet can cause sudden gush of venom getting injected in the bloodstream, and the patient can deteriorate sometimes. So this is like maybe our theoretical concept, or not sure very about it, but once we have a tourniquet, we can slowly release with the help of a BP cuff, and also the edema will start settling down. So we'll come to know that whether the edema is due to the snake bite or whether it is due to the tourniquet. So that is one thing that we can practice, what we can try. but because there is no randomized RCTs or anything, like we will not be able to say. So these are the little bit small practices that we have heard from the senior physicians who has been managing snakebite for a long time, and we have taken tips from them, and this has been a challenging part to us also. So this is a small practice that we do, which might help the patient in sudden increase of the venom.
Okay. In such situations, if there is already definitive signs of envenomation, do you think any role of starting ASV upfront before?
That is again local. It is a very big question mark whether we can start or not, because we are not sure because of the tourniquet. Because you have other features like ptosis. If you have like already your turbinate WBCT, meanwhile it has come positive, then you start your anti-snake venom. Then you release the tourniquet. There is no problem. So again, very relevant question what you asked, whether there is any other features. You need to start. Many people practices that only after starting anti-snake venom you release the tourniquet. There has been practices like that also. But local features we will not be able to say from this tourniquet. So that is the only reason. An early release and with the help of a BP cuff, maybe plus or minus anti-snake venom early, depending upon other clinical features.
Thank you. Next question to Girish sir. So the key thing in management, as we all know, is the antistake venom. So if you can elaborate on the dose and how to give or how long you can give and when to repeat also.
Actually, when we are talking about anti-snake venom, as doctors, we should understand how it is produced. Okay. It is produced by injecting venom to a hose, and from that hose, we are taking antibodies or taking the serum and taking antibodies, and this ultimately the hose will die. Okay. And because of this process, previously we never used to get anti-snake venom at right dose because the number has come down, the production has come down. But now we are getting whatever it is. At that point of time, we understood that which was given in 100 vials, 200 vials, that was wrong. We used to give very high dose that time. Once the scarcity occurred, the dose has come down. WHO has given some guidelines for this. Now the dose has come down to nearly 10 vials for an average bite. We'll see how what is this. True. So when we have a snake bite in our emergency room, even if we see the snake, suppose there is no clinical feature, no need to treat. We should actually wait for the clinical feature to occur. Yeah. Because in a bite, normally clinical feature occur fast in neurological bite. But the problem is viper bite. That may create some confusion among the doctors because normally it comes on the next day or second day. Even the crate bite, there will not be much clinical finding locally initially. True. But all these patients ultimately develop systemic manifestation. Okay. And we have some investigation like PTNR, Dr. Suresh has already explained. We have a point of care PTNR. So we have some advantage. We can do PTNR very early itself. We can see the blood WBC count. So clinical features and some laboratory investigation will tell you that definitely there is an envenomation. If there is envenomation, we have to start only one drug, that is ASV. True. ASV, when we are taking ASV, when we are giving, I have decided to give ASV for a patient who is having snake bite. No need to give test dose. Yeah. Most of the drugs what we give in emergency medicine require test dose, but ASV does not. Previously, it was given for a longer time, it was practiced. Now, WHO or all authorities definitely told there is no need of test dose. We are wasting our time. True. And sometimes it may be creating problem after the real dose. Yeah. So, no need to give test dose. Second thing is, when we are getting ASV as a powder form, we have to dilute it. Yeah. One vial should be diluted in 10 ml. Okay. So, normally, what is a recommended dose is for almost all snakes in India, what is big 4 we have explained, its maximum is 10 vials, initial dose. Okay. So, I decided to give 10 vials. So, all depends on my clinical experience or the doctor's clinical experience. So, I decided to give 10 vials. Okay. So, I take 10 vials, dilute in 100 ml of normal saline. So, 10 ml, each vial should be diluted in 10 ml. Okay. That should be given over 100 minutes. That means one vial should be diluted in 10 ml of normal saline. It should be given over 10 minutes. Okay. So, 10 vials I am taking, it should be given 100 minutes, 1.5 hours. Okay. So, when I am giving ASV, I should think that there is a high chance of ASV reactions.
True.
It is very less. At least now for our center, the number of reactions are very less. But even then, it can happen.
Okay.
So we should anticipate a reaction. We should make sure that drugs like adrenaline and all will be ready available.
Okay.
Some doctors even give pre-medications.
Okay.
They give drugs for pre-medications.
Okay.
That is also recommended now. Okay. That all depends on the doctor's experience, confidence. There is no guidelines. Set guidelines are not there.
Yeah.
But pre-medication can be given to prevent the reactions.
Okay.
Then we start ASV. The problem is with ASV is most of the time we start ASV and we go from the scene. That is not correct when we are giving ASV.
Yeah.
We should continuously monitor like we are giving streptokinase.
Yeah.
1 hour we are monitoring. We have to monitor. During the therapy, patient can develop so many problems. So we have to monitor. We give over 1.5 hours we have to give. Sometimes reaction can occur.
Yeah.
We stop the infusion. If depending on the reaction, you can give CPM or adrenaline, whatever it is.
Yeah.
But once the reaction has recovered, we have to restart. There is no other choice.
Okay.
Restart the ASV in a lower dose, complete the dose. Second thing is the maximum dose recommended for Indian bites, Indian snake bites for the ASVs, maximum is 30 vials.
Overall.
Overall is 30 vials, maximum.
Yeah.
Maximum.
Yeah.
But most of the bites may require 10 to 15 vials.
Okay.
As my experience says that these patients require 30 vials. This all depends on the experience of the clinician. We don't have set guidelines. Guidelines are there, but most of the doctors may not follow it. But I decided to give 30 vials.
Okay.
I should not wait for the second day, third day to give this 30 vials. I have decided to give 30 vials. First day itself I have to give 30 vials.
Okay.
Why this is important? Because these toxins or snake venom will go and attach the targets in various tissues of our body. Once it is attached, we cannot do anything. Before it is attaching, we have to give anti-snake venom and neutralize these toxins. So once it is attached to our human organ, we cannot reverse it. So whatever we decide, the doctor decide, you have to give as a full dose. But most of the bites, we have to give only 10 vials.
Okay.
Many patients recover with 10 vials. Some patients may require additional doses.
Repeat doses.
But whatever it is, you have to give immediately.
possible.
And you can use your laboratory investigations like PTNR, frequent PTNR, every 6 hour PTNR, all these things to decide
Okay.
further doses required. But whatever it is, give all these 30 vials you have decided to give the first day.
Okay.
Not on the second day, third day,
Okay.
continuous infusion, TID, QID doses. That's all recommended, not recommended.
Yeah.
Okay.
Okay, sir. That very well clears any doubts in that regard. Moving on to the next question to Krishna. Sir already explained in detail regarding the role of ASV. The other thing comes, pharmacological management, everything comes specifically in neurotoxic envenomation. If you can elaborate a little bit more on that, especially with neostigmine and all.
So the standard anti-snake venom therapy is the same. There is no confusion. Whatever Sir has told, that has to happen for the neurotoxic envenomation also. So now the additional therapies like with neostigmine, physostigmine, whatever pyridostigmine, whatever is available, now that is the question. So as I told before, there are two ways that you can, sometimes very rarely you need to have a diagnosis also. Whether it is a snake bite, like we do the tensilon test for myasthenia gravis. So somebody's come unconscious or somebody was lying on the floor last night and suddenly brought with an acute flaccid paralysis. We are not sure whether it is a snake bite. So big question comes, can we deliver anti-snake venom? Because the availability, as I told, the availability is very limited. So in that scenario, we want to confirm or we need to have a clue whether it can be a snake bite. So that is one thing. Second, for the treatment per se itself. So coming to whatever be the method, whatever we are using it, whether it is a diagnostic for the treatment purpose, the role of neostigmine, there is definitely a role, whether it is in crate or whether it is in the cobra bite, definitely it has got a role. There can be centers where anti-snake venom is not available. So you need to shift the patient to a center where an ASV is available. So already there is a center where ASV is available. Sometimes you need to add an adjunct to it. So like that, you have to pre-treat the patient with atropine to prevent the bradycardia caused by the physostigmine or neostigmine, whichever drug you have. and you need to give the neostickmin next. So, for example, if you give 1 ampule of atropine, you need to give 1 to 2 mg of neostickmin and look for the response. So, for that reason, you should have documented everything. So, if the patient has got ptosis, so we can, maybe you have all smartphones with us, we can just took a video of the patient. What was the ptosis prior to the administration of neostickmin? We can see the respiratory rate or the single breath count, and see how the patient is improving after 5 minutes after giving the drug. If there is definitely improvement after giving this, that means our drug is working, and we can continue this drug maybe 2nd hourly, 4th hourly, 6th hourly, and later we can taper down and stop. So this is an adjunctive therapy to whatever which is set to anti-snake venom. So that will be the role.
Very clear. Next question to Darshan sir. Sir, what it's about the role of intubation in snake bite. When will we decide when to intubate, or any specific drugs we need to consider?
Okay. Regarding the intubation, there are two occasions in the two way the decision making goes. One, the patient is suddenly deteriorating. So there is no time window, we have to go for the technique called rapid sequence intubation.
Yes.
Otherwise, as a clinical assessment of the patient is going on, especially in neurotoxic. So we could able to assess where the patient is.
Okay.
Whether he is progressing further and further like that.
Okay.
So that indicates anticipated intubation also we can be doing.
Okay.
So for example, in neurotoxic there will be bulbar pulse and the cranial nerves are affected. So these things may cause airway obstruction, even a laryngospasm.
Okay.
So this thing may also be happening.
Okay.
And then
Okay.
inadequacy of the ventilation.
Okay.
So inadequacy of the ventilation, the diaphragm is the last muscle to be get paralyzed. So it will take long time. So earlier anticipation and assessment we can plan, and accordingly we will intubate.
Okay.
So in a crisis situation we have to go for the rapid sequence intubation.
Okay. Regarding the paralytics, anything we need to
So
keep in mind?
regarding
slowly
this one, not only the drug selection
Okay.
and all the 7 P's as it is being adhered to all
Yeah.
other systems,
Yeah.
this should also be incorporated herein.
Okay.
So the drug selection depends upon the clinical status.
Okay.
As far as the induction agents are concerned, so depending upon the hemodynamic stability.
Okay, sir.
So one is the normal BP or the pulse rate, or the BP is very low. So in situations whether it's a normal BP or little higher side, etomidate can be taken.
Okay, sir.
And even mild BP fall also etomidate can help.
Okay. Okay.
So otherwise we can opt for a low BP
Okay.
level, we can go for the ketamine.
Okay.
So ketamine is having both analgesic as well as the induction properties, but etomidate is not having.
Okay.
So otherwise BP is normal on the higher side, we can even select a propofol.
Okay.
Both etomidate and propofol can be preceded by the fentanyl. So whenever we have that. Regarding the muscle action, see here in the snake bites, neurotoxic especially, and all other things, better avoid suxametonia. See, especially in hematotoxic, there will be release of muscle damage, a lot of potassium will be there, hyperkalemia will be there, arrhythmias are anticipated. So better go for the non-depolarizing agents. So out of the non-depolarizing agents, because there is a renal involvement, most of the cases, but a self-degradation muscle relaxants like atracurium or cisatracurium or choice, if it is an anticipated intubation, the rapid sequence intubation means we can go for the rocuronium.
Rocuronium, yeah.
See, apart from all these things, as far as the intubation is concerned, so certain other things we have to keep in mind.
Okay, sir.
That is the degree of the muscle paralysis. So as we were talking before regarding the establishment of the airway and then maintenance of the airway.
Okay.
So in the initial stage and
Okay.
the pre-oxygenation.
Okay.
So these things depends upon the ventilatory adequacy.
Okay.
If the ventilation is inadequate, we have to go for the bag mask ventilation.
Right.
Sometimes apart from maneuvers, we have to go for the airway adjuncts like oropharyngeal or nasopharyngeal. So here the one most important thing you have to keep in hematotoxic, where the bleeding tendency is more, then we have to avoid the nasopharyngeal airway.
Okay, sir.
So it will
Right,
further
right.
increase. Then we can go for the oropharyngeal airway.
Okay.
See, apart from that, the procedure in hematotoxic, this thing
Yeah.
should be very gentle.
Yeah.
So there may be bleeding into the oropharynx, nasopharynx, upper airway. So it has to be cleared. So the suctioning and the laryngoscopy or intubation itself should be done atraumatic way in a gentle manner. So these are all things. Apart from that, the toxicity, the hemodynamic may be very badly compromised.
Okay.
The patient may even in shock or hypotension, sugar coagulation problems and renal problems, all these things should be weighed, and accordingly we have to select it.
Right, sir.
And regarding the neurotoxic, as already talked
Yes, sir.
about, only ventilation, pre-oxygenation part is most important.
Okay, sir.
Okay.
Right, sir. Very clear, sir. Moving on to Krishna, sir already told that there is no role for test dose. But if at all the patient develops an anaphylaxis, then what are the next steps to follow?
Whenever we discuss regarding management of anaphylaxis, the first step should be stopping the culprit agent. So like this, it is due to the anti-snake venom. So approximately 20 to 40%, that is a percentage of anaphylaxis that we can anticipate following an anti-snake venom. But now it has slightly decreased because of the purity of the products what we are receiving. So to our experience, less than 10%. So that is our institutional experience. So the first thing that you need to do is stop the anti-snake venom. But you need to continue it later, and you treat the withhold for the time being, and continue your routine management for the management of anaphylaxis, like that the standard doses of adrenaline. So again, the question comes whether can we give IM injection because the patient is already having an hematological manifestation. Can we give an IM injection? But in a center where you are giving anti-snake venom, there will be a well-trained person to give an IV adrenaline. So like that, we can just start like a normal infusion, like 0.01 microgram per kilogram per kg. Then like we start noradrenaline for our septic shock. Similarly, the same dosing we can take adrenaline, and we can start as an IV infusion. So not bolus like what we do in cardiac arrest. That is a wrong practice. Should not give just like 1 mg 1 in 1000 dilution bolus. That should not be done. Maybe you are very confident, you can dilute it to 1 in 1000 or 1 in 1 lakh, and then you can dilute and you can give it as a 1 ml IV bolus. Not 1 in 1000 dilution, 1 in 1000, 1 in 10,000 or 1 in 1 lakh. So that should be the dilution that we should be using for the adrenaline. Then again, the role of
1 in 1000 we have to explain. 1 in 1000 means 1 ml, 1 adrenaline.
One adrenaline. So yeah, the standard thing that we will get is 1 in 1000. That is 1 ml that we will get. So what you have to do, take this 1 ml, you dilute it into, if you want to make it 1 in 10,000, you add it to 10 ml. And from that you take 1 ml and you give it as an IV. You want to make it 1 in 1 lakh, you add this to 100 ml. From that take you 1 ml and give it as an IV. So I think that clarifies what is the dilutions are. So that is regarding the adrenaline part. And most importantly, pre-medications. Maybe there is a high risk of anaphylaxis, already existing anaphylaxis. Already there is a drug history of many anaphylaxis. You want to be on a safer side, you can pre-medicate. Otherwise, routinely pre-medication is not needed. Next thing is that regarding the role of steroids, like we does for any other anaphylaxis, 1 milligram per kilogram body weight of hydrocortisone or methylprednisolone, whatever be the drug that is available, you can give steroids. Then your chlorpheniramine maleate and your other antihistamines like ranitidine, cimetidine, any of this drug, whatever is available, you can give. So that will be the routine, and the problem will be hypotension, anaphylactic shock. So you have to tackle that also with the routine crystalloids management, and followed by maybe an adrenaline infusion. And later on, you need to start ASV. There is no point in withholding the ASV. Later on, once the scenario improves, you slowly restart the anti-snake venom. Maybe in one hand it will be ASV, and on the other hand it will be an adrenaline infusion. But you don't have any other choice. But it is a different situation. But usually when anaphylaxis, we should not giving that drug again. But in snakebite, we don't have any other option. We need to give this drug. So that will be the management.
Very clear, Krishna. Next question to Girish sir. Sir, as we all know, there is some role for blood products and cryoprecipitates and all in the management of snakebite. If you can elaborate on that.
Okay. Like Sri Krishnan first itself told, PTNR is one of the most important investigation, or 20 minutes whole blood clotting time in a peripheral setting. So we will be observing that. If the PTNR elevates more than 1.5, that is an indication to transfuse FFP. Okay, I am telling in a normal person, not in a person who is already having a problem, like somebody is on warfarin or somebody is having chronic liver disease. That they will not come to this discussion. A normal person who is having a viper bite, having a PTNR more than 1.5, he qualifies for a FFP transfusion.
Okay.
So in that case, we are giving FFP, fresh frozen plasma. Now, when the patient is having elevated PTNR, one more important test we have to do, that is APTT. You know that there are two different pathways, intrinsic pathway and extrinsic pathway. So, one pathway will be done by PTNR, another pathway will be done by APTT.
Okay.
If both pathways are damaged, like PTNR is elevated, APTT is elevated, then you have to do fibrinogen levels.
Okay.
Normal fibrinogen level will be more than 150.
Okay.
So if it is less than 100 or less than 150 itself, we should be very careful.
Okay.
And if it is less than 100, we have to add cryoprecipitate to this FFP.
Okay.
Why cryoprecipitate is, now we are dealing, the PTNR is elevated, APTT is elevated, fibrinogen is low, means it's an indication to tell that this patient has gone to DIC.
Okay.
So initial phase, there will be thrombus formation inside our blood vessels in DIC. Then there will be coagulation. All these products will be utilized for that coagulation problem. And already because of viper bite, this liver is not producing adequate coagulation factors. Okay. So a lot of issues are there. Fibrin production is more, fibrin destruction is more, coagulation factors are utilized. Okay. So everything is gone. Okay. So we have to give fresh frozen plasma with cryoprecipitate.
Okay.
That depends on the body weight we are giving.
Okay.
Okay, not blindly we are giving. So FFP and cryoprecipitate should be given in a composition, as a composition if it is DIC.
Okay.
If it is only PTNR is elevated, then we give FFP.
Okay.
But unnecessarily we should not give FFP and cryoprecipitate. Yeah. Blood transfusion should be reserved only for the patient who is having anemia less than 7.
Okay.
Or if you are taking this patient for a fasciotomy, continuous bleeding is there, you require blood, anticipate a bleeding, then you can transfuse. Okay. Before the surgery, you can transfuse and make it more than 10 and take the patients for surgery. Fine. Unnecessarily, in a snake bite, we should not transfuse because this will create more problems like post-transfusion, renal injury and all can occur. So we should be very careful.
Okay. Very clear, sir. Next question to Krishna. Can you share your views on the role of dialysis and also new therapies like your cytosoap therapy in snake bite?
So, first coming to the indications for dialysis, as we all know, indications for dialysis is for renal issues or maybe an electrolyte related issues or metabolic acidosis. So the patient is having a persistent oliguria and the patient has gone for a metabolic acidosis. So there is an ongoing hyperkalemia which is not managed by our routine drugs. So general indications as such, we can go for dialysis. Otherwise, there is no need for dialysis for the removal of the toxin. So that is not needed. The treatment is giving anti-snake venom. Why I am telling is that many people think that we are doing dialysis to remove the snake venom. It is not to remove the snake venom. It is what we are doing for the other indications like renal failure secondary to acute tubular necrosis, metabolic acidosis related to that, and hyperkalemia. So that will be the indications for the dialysis as such. Now coming to the newer cytosoap therapy, as we know, like in any sepsis, there can be a cytokine storm in this group of patients also. So when we need to suspect this, so your initial therapy you have done, but still the patient is not improving. You are evaluating the ferritin level is going up, your LDH, all your triglyceride levels, everything is going up and is fitting for an HLH sort of a criteria or a cytokine storm that we will see in any of like COVID. We are very much familiar with the term cytokine storm. Then there is a limited study series that we have seen. We had a couple of patient experience where the cytosoap therapy has helped just like in any other scenario, maybe a dengue related HLH or maybe an leptospirosis related cytokine storm, just like that. Similarly, we had an experience with cytosoap therapy for the patient with snakebite also. For both the patients recovered very well, and that was our experience regarding that.
Last question to Girish sir. We have all discussed regarding the acute management and all, but we at times see some long-term complications also with snakebite.
So,
if you can.
Long-term complication, when we see the books have given that complication is mainly pituitary hemorrhage. Okay. But one of the most important complication I have seen, or many doctors have seen, is the local skin problem. Okay. Like especially in viper bite. You get long-term cellulitis in that limb, long-term infections, that skin will be completely, that there will not be any hair, nothing will be there, no sweating, due to some reason, maybe the local destruction. Okay. But long-term infections are main problem in viper bites. So we normally give pendits, that's a penicillin prophylaxis given for cellulitis for all these patients to prevent repeated infection. At least 3-4 years if you give, that skin will become normal after some times, and then they can have a normal skin.
Okay.
Another thing which is well explained in books, and we have seen many patients also, that is pituitary hemorrhage.
Okay.
That produces some hormonal changes in patients, especially what we are seeing in young males. Their testosterone levels have gone down and their normal growth will come down. They require frequent monitoring of testosterone, and we have to give testosterone for many patients. So there is one of the problem of this viper bite, not in other bites. Cobra bite and all, normally it will not produce any post-bite complication. But viper bite definitely can have chronic kidney failure, chronic skin problem, chronic pituitary related hormonal changes.
Okay.
So all these things we have to correct on the follow-up.
Yeah. Okay, sir. I think with that we will come to the end of the questions. I think we have covered almost most of the relevant topics, and also some not so very commonly discussed concerns with snakebite also. Now we will move on to the viewer questions. Before that, one request to all viewers. Our plan is to continue with this panel discussion at least one per week. So if you have any topics in mind, do feel free to share it in the chat box or also later on in the comment section. I'll move on to the questions. There is a few compliments coming up. Yeah, Watson Day says I don't think that a snake is poisonous, it is venomous. Yeah. John Wesley says, sir, is there any condition where the antistake venom is contraindicated?
Again, there is no as such contraindication. It is actually a life-saving medication. So whether there was a previous anaphylaxis, that's what we usually say it is contraindicated, but you don't have any other choice to give. We don't have any monovalent anti-snake venom for a specific therapy. Only what we have is the polyvalent anti-snake venom that is available in India right now. Maybe later on research comes up, maybe we'll have monovalent therapy. Maybe at that time we can think, but as such now there is no contraindications to give anti-snake venom. Even if this patient, I am telling, life-threatening anaphylaxis in front of you, you have to give anti-snake venom. There is no other go. Thanks,
Krishna. Milind asks what to do in the first aid or emergency. Already we have discussed it. Thanks, Milind. Dr. Michael Paul, what is the dose of anti-snake venom? That also we have answered. Hi from Living Earth.
30 vials.
Yeah.
That is the dose. Yes. Exact dose we can put it in the, if you send a mail, we will send the guidelines.
Okay.
But, normally we give 10 vials.
Yes, sir.
Maximum is 30 vials, not more than that.
Okay. A hi from Living Earth. Then Dr. Jeffrey. If we have ASV but we don't know whether the snake is poisonous or non-poisonous, even after 5 minutes of a bite, there is no symptoms, will we use ASV or not?
So that all depends on the clinician's experience. So I cannot tell without any clinical finding you should give. Normally what is recommended is if there is no clinical finding, don't give. But when you are anticipating, suppose you have seen the viper, you have seen a viper, and even if there is no local reaction immediately after a bite, you are anticipating that's a strong bite.
Okay, sir.
Then definitely we have to give. We cannot take any risk because this clinical finding may occur in the next day.
Okay.
So in that such situations, your experience is most important. Okay. There is no set guidelines.
Okay. Pat Russell, love you, sirs. Love you too, Pat Russell. Thanks for the support. What is the difference? I think we'll discuss it later. What's the maximum ASP dose? What if the effect of venom stays even after giving 30 vials? Is there any infusion protocol?
Okay. So the question comes, how we reach the value of 30? And what will you do when the patient is still having more than 30? Okay. So that part is a little bit covered, like the role of blood products. So why this is 30? Why it has come? So actually there has been some consensus regarding this. There has been a lot of animal research and on behind this, and they have come to know that the maximum venom injected is by the Russell's viper. Okay. On an average, it injects around 63 mg. So in order to neutralize this 63 mg, we need approximately 10 vials. Okay. So that is why the 10 vials count has come. So the maximum amount injected was found to be again 147. So to neutralize this 147 mg venom quantity. So to neutralize this 147 mg, we need approximately 20 to 25 vials. Okay. So taking to the account little bit more, that is why we are saying 30 vials is the maximum. Okay. So each ml will neutralize around 0.6 mg venom of the Russell's viper, 0.6 mg of the Indian cobra, 0.4 mg of the crate, Indian crate, the common crate, and 0.4 mg of the saw scale viper. So that is how we have come up with the dosing. So if it is above like 30 vials, one thing it can be you need to give your blood products, or second thing you are not treating the big four. You are treating the, maybe it is a HNOS with vapor, or there is something else, or there is very rare chance of resistance also. So this will be the reasons.
Moving on to further questions, Pat Russell asks, what are the prompt actions after getting snake bite? I think we have discussed it. Okay, thanks for the compliments, Pat. Nazaruddin asks, max dose of ASP. I think we have already covered that. Aishwarya S. Murthy. So should we always give ASP in D5?
Always.
Dextrose, 5% dextrose.
It is normally recommended in normal saline. We have never tried in D5. I think there is no contraindication, but however, any drug when we are practicing, we have to read the product leaflet along with the product, because anytime this product can be changed, their preservatives can be changed. They advise what to be used, but we normally use normal saline. I think there is no issue with.
We also have some liquid forms.
See, actually, the question is that we have two formulations that is available. We have a freeze-dried powder, which will have that distilled water along with it, which we need to dilute. And again, this question arises when we are giving it as an infusion protocol. As there are two methods of giving anti-snake venom. One is the direct IV push, and the other is the infusion one. So when you think of direct IV push, there is no need of further dilution. Whatever you're taking 10 vials of ASV, it will be 100 ml. So you can give it as 1 to 2 ml per minute. But there is another protocol also where you can add this 100 ml to a 500 ml, and we can give it over 1 hour. So that is also being practiced. So in that scenario, normal saline or dextrose, 5% dextrose can be tried. But only thing is that you have to look for the color change. Whether again, the initial itself you need to look for the color change, and after adding also you need to look for the color change. So ideal recommendation to be on a safer side will be normal saline.
Very clear. Kotireddy asks, any pediatric dose of ASV?
Whether the victim is pediatric or adult, whether the snake is pediatric or adult, that means small snake or big snake, we are treating the clinical scenario. It is not weight dependent ASV. We are giving the full dose of ASV, whether it is a child or adult, whether the snake is a small snake or big snake. All depends on what is your clinical finding, how much strong is the clinical finding. But most of these patients may require 10 vials, even if it is pediatric.
Yes, very clear, sir. Russell asks, Akshay says thanks. Russell asks, any variation in therapy during pandemic times? How do you treat snake bites if the patient also has COVID-19? I think the core concepts remains the same. Yeah. Mohammed.
Thrombotic chances will be more.
True.
So that is the only thing. We thinking in terms of bleeding, and other side there can be risk of thrombotic changes also. So one side you need to treat the with your anti-snake venom, maybe FFP, maybe thrombosis risk you have to consider giving heparin also. So that's a double source, risk versus benefit, whichever is the priority, because in this situation the snake bite is going to kill before COVID-19. So you treat the snake bite, then go ahead with your COVID-19 management. So we had few case reports where discussion in our chat groups regarding this.
So there is no compromise on the snake bite management is the key message. Siddiqui says thank you. Fayaz asks, if we identify the snake as pit viper, can we try giving ASV? I think we
have to give ASV. We have to give ASV because some reports are there, cross reaction, sensitivity will be there. Some vipers ASV will have action against many viper venoms. But what we have observed is the ASV action will not be like a normal viper. So definitely we have to give ASV. We have to wait for the thing.
Yes, sir. Next question is, Mohammed asks, can we discuss OPC poisoning? Yes, definitely. Divash asks, how to treat snake bite cases in first, second and third trimester of pregnancy case with their contraindication?
There is no.
Core management remains the same. Fayaz asks, which guideline says 10 vial 100 ml for 100 minutes?
So the question comes, the thing is that when you dilute it, each vial will be 10 ml. So if you take 10 vials, it will be 100 ml. So the dosage of ASV is 1 to 2 ml per minute. So if you are planning to give it will take 100 minutes. So 1 ml per minute, it will take 100 minutes. So the guidelines, what we all follow is that Southeast Asian region guidelines specifically formed to the Southeast Asian by the WHO. Maybe 3 years down the line, they have come with certain updates. So this is the guidelines that we follow for the management of snake bite, and there is an Indian consensus also, which is almost the same, which is the same as that what WHO has said.
Ashish asks, basically the question says that is there any interaction between COVID vaccine and ASV? So I think true. Yeah, I think that's it. John Wesley says, thank you for the information, and can you panel discussion on OP poisoning? Then looks like a popular request for OP poisoning. We will definitely consider it. Any complication of patient? Okay. There's a lot of questions coming up with COVID and snakebite. I think the core principles of management of snakebite will remain same. We cannot unfortunately compromise on the management of snakebite as ASV definitely will need to be given. I think with that we will close the session. Any comments from anybody? No. Okay. So a special thanks to all who saw the event live and has been putting in your questions. Looking forward for future interactions also. Thank you. Have a good day.
Thank you.
Thank you so much.